Good afternoon, and welcome to HIT Policy Update with Dr Halamka, MD, CIO at Beth Israel Deaconess Medical Center, a complimentary webinar from HealthSystemCIO.com sponsored by OnBase by Highland. A little housekeeping before we get moving. My name is Anthony Guerra. I'm the Editor-in-Chief of HealthSystemCIO.com, and I will be your moderator today. Questions, we encourage them. Type them into the Q&A box in the lower right-hand corner of your screen at any time, and leave the default set to all panelists. I'll be posing those to Dr. Halamka later in the program. And you can download the deck. You see the URL on your screen. There's also a shortened URL on each slide, and I'll send it out in the chat box, so you'll have plenty of chances to get a hold of the deck. We will have an archive, a recording available of this event within 2 business days. You'll get an email, and a separate registration is required. Just so you see how we're going to spend our time today, we're going to go about 45 minutes. First, we're going to hear from Dr. Halamka, and then we're going to hear from our sponsor, represented by Lorna Green, Senior Healthcare Informaticist with OnBase by Highland. And then we're going to have our Q&A with Dr. Halamka. So, without further delay, we're going to turn it over to our good friend, Dr. John Halamka. Dr. Halamka?
Well, thanks very much, and I always enjoy doing these because it gives me an opportunity to chat with folks as to what I know is happening from a policy perspective, what I think is going to happen from a policy perspective. And certainly quite a lot going on as we now have ended the first reporting period in the first year of Meaningful Use Stage 2 for hospitals and get a sense of how we're doing as hospitals and doctors. And we're thinking about what is the next stage of meaningful use, and are we feeling fatigued, and what are we going to do with ICD10, the HIPAA Omnibus Rule? What are we going to do with ACA? So, as is usual, Anthony, I will try to give updates on the 4 big regulations, pieces of legislation. But I also wanted to reflect for a minute on social, mobile, analytics, and cloud, given that in the last month we have seen the introduction of iOS 8, HealthKit, Apple Watch is coming. Where is all this consumer-grade home telemetry technology going, and how, especially with the notion of the Affordable Care Act and focusing on wellness rather than sickness, might it play a part in our healthcare systems? So let's go directly to meaningful use. So as I said, reporting period for Stage 2, first year, has ended as of September 30th. And the numbers are not yet in because, of course, we have until November 30th to finish hospital attestation, and then the reporting periods for eligible professionals do go through the end of the year, and March is the deadline for reporting period there. But what I hear from all of my hospital CIO colleagues is there have been significant challenges, particularly around the transition of care summary transmission and patient-family engagement. And Farzad, very visionary guy, felt that it would be important to try to move the industry in areas that it didn't really want to move because an ecosystem of changes, a culture change, a behavioral change was required. But nonetheless, those were in Stage 2, and what we saw is if you are going to send a transition of care to 10% of all the PCPs, specialists, or next providers of care for your patients, they need to be connected to a health information exchange or be able to receive what you send. And of course, in many regions in the United States, it's as if the hospital has the only fax machine in town and there's no one to fax to. So that's been a real challenge. And what have we seen? Well, Bon Secours actually sought a legal opinion on the following issue. What if I run Epic, but I am a hospital and I have a hospital tax ID? But all these docs who I don't own use that Epic system to read, say, transition of care information from a hospital stay. What if Bon Secours sends transitions of care to Bon Secours, and a person, a doc, with a different tax ID then views them even within the same software? Is that a demonstration of a transition of care? And the answer has been yes. So you'll find on the CMS FAQ page, you'll find even in Epic's annual meeting, this notion of a selfie, of sending a transition of care to yourself, is deemed acceptable. And certainly, I think the spirit of meaningful use was to try to go across DHRs and across communities. Our challenge is that many of the communities in the country aren't quite ready yet. Massachusetts, luckily, does have a robust health information exchange with millions of transactions and thousands of doctors, about two-thirds of the doctors in the state already connected to it, so achieving a 10% number was quite possible, but that was an ecosystem and environmental issue local to Massachusetts. So especially also on the patient-family engagement, we're seeing some struggle. Patients and families absolutely want access to their information, want their care preferences respected, and want care coordination, but many organizations in many areas of the country haven't widely marketed the patient-family engagement capabilities, so patients aren't quite sure what to sign up for or how to use it. Again, you're seeing some sort of interesting workarounds. Just like the selfie in transitions of care, you're seeing a discharge process that goes something like, well, Mrs. Smith, here, I want to log you into this website so you can see your discharge instructions. Okay. Well, in the discharge process, you have had a single view of data, which would now hit the numerator for the patient-family engagement requirement of 5% of patients accessing their data. Again, not quite what the regulation intended, but I completely understand it, given the nature of the cultural and behavioral and marketing aspects of patient-family engagement that just need a little more time. So in the spirit of a little more time, we of course have the meaningful use stage 2 delay, which in some ways is a non-delay. You were given the opportunity, if you had hardship, to use the July through September 2014 reporting period for stage 1 criteria and 2014 quality criteria. And so first, of course, what is hardship? That's a little hard to measure. One of my hospitals, for example, uses Meditech, a 5.66 magic version, and they received in time a version of certified software. So that really wasn't a hardship. However, it wasn't just Meditech. They used lots of other vendor products and modules, especially around patient-family engagement and interoperability, and those weren't quite ready in a timely way to get training and ensure they were used appropriately. So this hospital will declare a hardship not based on the core of its EHR, but on the add-on products. So fine, you declare hardship July 1 through September 30th, and you use the meaningful use stage 1 criteria. But as written, the delay does not affect 2015. So that means you have a still full year reporting period. You won't be ready on September 30th, but you'll be fully ready by October 1st. It's pretty clear that if you are going to have a meaningful delay, what you needed was not only the ability to use stage 1 for that July to September time frame in 2014, but a 90-day attestation period in 2015. Saying, I'm going to get my ecosystem, I'm going to get my marketing, I'm going to get it all lined up, and you're going to give me 9 months to do it, well, that's okay. So Congress, on September 16th, introduced H.R. 5481, which intends to provide that 90-day attestation flexibility, giving hospitals in the U.S. the capacity to wait until July 1 to really take the stage 2 measures and widely implement them. And there is the notion, too, remember that the 2014 reporting year is that year to be used to calculate your penalties in 2016. So H.R. 5481 is also intended not only to help us get over the finish line, but avoid unnecessary penalties. So that's stage 2. Stage 3 is being written right now. In fact, of course, I've not seen any of this. It's all in government circles, but I hear that the draft is complete and being circulated for clearance. And so who knows precisely what it says. But what I hope is that it is less burdensome, it is less prescriptive than stage 2. There were just too many specific workflows to implement in stage 2, and this is what caused a lot of EHR vendors to create highly unusable software and a lot of organizations to struggle with its implementation. I'm hopeful that stage 3 is skinnied down, that stage 3 gives us more outcomes rather than prescriptive processes. And one thing that you should know is that stage 3 fact, really even starting now, we're seeing a decoupling of certification and attestation. Now, what does that even mean? Well, remember that a piece of software has certain characteristics. That's certification. How you use it, that is attestation. And in the past, there was sort of this idea that certification was a giant, big EHR and that it was very closely linked with the attestation function. Well, what I think you're seeing is that EHR vendors, though they've tried very hard, it's impossible to put a yearly new version out into the environment, get everybody fully implemented and trained, make it secure and bug-free. So what you're starting to see is this certification idea of we're going to create smaller incremental feature changes in certification year to year, and some will even be voluntary. Decoupling the forced march through version upgrades of certification from attestation. So you could have a piece of software that doesn't have all the latest and greatest features and still attest with it. You as a vendor can move forward in a more thoughtful and incremental way so you can innovate as well as incorporate some of the smaller changes that certification, now incremental, would imply. So the Standards Committee, in many ways, is no longer going to focus on meaningful use. Office of National Coordinator is not the meaningful use office. We are going to more focus on, well, what are those incremental changes that we need to plug gaps in interoperability? Pick up the New York Times, it says, interoperability doesn't work. Well, what do you mean by that? Does public health work? Well, yes, public health works. Transitions of care work? Well, yeah, transitions of care works. However, clinical research doesn't work so well, or you show up in an emergency department and a doctor wants to pull your allergies from every site in the community where you have consented to release it. That's not quite working yet. Okay, fine. Let us focus on accelerating the standards necessary to fill those gaps, and that is really more about quality, safety, and efficiency. It is not so much about meaningful use. So I think you'll watch the language out of ONC in the ensuing months focused on interoperability, closing gaps, supporting new architectures and use cases, and not so much just a meaningful use-focused activity. Now remember, there were 19 proposals that went into the meaningful use writing process. Not clear exactly how many of these are going to make it into the Notice of Proposed Rulemaking, and hopefully we'll see that draft by the end of the year. But I mean, some good things. The idea that we will have nationally curated clinical decision support guidelines and protocols that can be incorporated into the EHR or called from the EHR. Closed-loop order tracking, so that as you order a lab and get a result back and it's abnormal, the patient is notified and follow-up is arranged and issues aren't lost or dropped. The idea that we'll make sure disparities of care are measured through better gathering of demographic data and stratifying quality measures in a variety of different ways. That your advance directive or physician orders for life-sustaining treatment are incorporated into the EHR. They may be hosted in the cloud. They may be hosted on your iPhone, but they're going to be accessible with your consent and incorporated into the EHR so that you don't have a resuscitation that's unwanted. Notes go electronic, no handwriting. Labs are fully encoded and not faxed. That if you have a pacemaker and the batteries go south, the manufacturer is able to contact you, do a replacement, understand throughout your life where your device has been touched or upgraded using universal device identifiers. Now that we're seeing new products enter the marketplace like Apple Health Kit, which I'll reflect on in a second, there may be a place to send your data. Today, view, download, transmit, part of stage 2, but really, where would you transmit it to? And so hence, be very interesting to see an ecosystem where you see a doctor, you see a hospitalist, you see an emergency department, and instead of having 3 PHRs, you're capable of getting that data sent to your phone where you become the steward of your own data. Not for everybody, but an interesting possibility. More and more, we're going to get data from the home. Talk about that in the context of ACA in a second. But that Fitbit or that bathroom scale or blood pressure monitor, data coming from those to your phone and then from your phone to an EHR will be really important as we look at variation and we look to make early intervention to prevent emergency department visits, repeat hospitalizations, unnecessary testing, and medical expense. Secure messaging, today we of course have in stage 2, but might there be ways to notify multiple members of your care team when events about you occur, coordinating your care more electronically than today's phone call or email. And of course, the patients have to understand what's being done to them and their choices, especially in non-English languages. That was a proposal. That as we go from place to place, transitions of care are important, but for those of you who have implemented the CCDA, which you may know is a lot of the CCDAs flowing today either have little information, a couple of meds, a couple of problems, very little to work with, or too much information, 17 different notes that are such amounts of free text, it's hard to discern their meaning. So how do we achieve meaningful text, meaningful structured results in those transition of care documents? Notifications I've hinted at already that maybe as you're admitted, your wife, your daughter, your mother, they're all automatically told with your consent about an admission, discharge, transfer, death type event so that that team around you helps coordinate your care. We already do MedRec, but there are ways we can do it better by getting access to data sources in a more automated way so that we get that medication reconciliation done with a sense of what medications have been filled, by whom and where. And then finally, a variety of public health issues, not only sending information to public health, but retrieving it. So a school nurse with parental consent could get access to the comprehensive immunization history and understand the gaps in, say, a student's immunizations. So these were the proposals, and again, many of them very good, some technically hard, some culturally challenging. But I have a feeling that we'll see, again, upcoming months, that there'll be a skinny down version of this with hopefully a lot of outcomes and a lot of flexibility, as opposed to every EHR vendor having its agenda for innovation co-opted by a very strict set of both attestation items and certification criteria. So I've already mentioned that we're decoupling certification and attestation, but you'll see in Congress an increasing interest in interoperability, and I think you'll see coming up on October 15th, the Policy Committee and the Standards Committee come together to review a straw man, early first draft of an interoperability roadmap for the country for the next 10 years. What are we going to work on? I mean, my sense is it's going to be more about query retrieve than sending around CCDA documents, the capacity to retrieve structured data elements from places they live today with patient consent when situationally appropriate, like an unplanned visit to the emergency department. Those kinds of interoperability items are certainly important to ONC and important to Congress. So a lot to come on October 15th. And Anthony, later tonight, I will publish a view of what that October 15th meeting might accomplish and some of the standards that it might suggest we move forward with. So ICD10, here it is, October 2nd of 2014, and ICD10 should have been live. But of course, we are delayed to October 1 of 2015, and that delay is welcome by all. And I can tell you from the Massachusetts community that neither the providers nor the payers are ready. Integrated testing isn't going so well. The idea that we are going to keep revenue cycles intact while moving from 16,000 to 170,000 codes is a stretch. And what I really hope, and you hear rumors on the Hill, just rumors, that there is still a chance that this whole project will be either scaled back, ICD-10 procedure codes no longer required, or will be delayed or eliminated. So right now, all on track, right? CMS hasn't signaled anything but an October 1, 2015 effective date. But still, we all know this has cost billions. It really helps no one, And I would suggest that providers especially are not going to be able to create the structured, detailed documentation to survive a RAC audit when, say, Anthony, I have a guinea fowl injury, but my doctor documents poultry. That would be fraud and abuse as opposed to getting the bird species right. I mean, this is just crazy. And so we need new tools and technologies, things like computer-assisted coding, and ways that I would hope turn clinical observations into clinically relevant observations like SNOMED codes as opposed to ICD10 codes. And you even wonder, in a world of global capitated risk, as we're moving away from fee-for-service as a country, is the whole concept of using ICD10 coding and billing as a revenue cycle item even something we want 10 years from now? So more to come on that. And certainly let's hope for a reduction in scope, the elimination of the procedure codes, the use of SNOMED, and the use of computer-assisted coding and technologies that make clinical documentation to coding more accurate and less burdensome. I travel the world a lot, and when I'm in China or Japan, I say, you know, the Obama administration spent $24 billion on healthcare IT. And they say, yeah, we hear you got a really bad website. Unfortunately, the world conflates ARA and Health Information Exchange with Health Insurance Exchange. And so, of course, to all of you, health insurance exchanges are very important, and we have our state and federal exchanges. But let's all, over the course of the next couple of years, do what we can to reduce redundant and wasteful care, to reduce cost and improve quality through robust implementation of health information exchanges, HIEs. And here are some of the ways that we need to do that. As each transition of care happens, not only are providers and patients told about the care delivered, but common registries in the community that are used by ACOs are populated so that care managers, non-physician extenders can look for gaps in care, variations from guidelines and protocols, arrange that home care visit or that teleservices visit. And at the same time, you might imagine, as we talk in just a second about the new devices, the patient-generated data, that home care can actually take into account that weight gain you had over the weekend and your congestive heart failure meds or your reduction in FEV1 or pulse ox that might happen to an asthma or COPD patient and prescribed steroids. That this world of wellness rather than sickness demands new IT solutions. So the standards to get data from EHRs and mobile devices into care management databases and the workflow to ensure you are cared for at home or in your local community instead of the emergency department or hospital readmission is an increasingly important theme. To that point, you know, this is an opinion, Anthony, purely an opinion, that I think the downtown expensive academic medical center in the next 10 years will have to shrink, and that minute clinic that's next to your home is going to start doing chemotherapy infusions, is going to start taking on a whole lot of the routine care today done in downtown settings, and will do it faster, cheaper, with equal quality. So for those of you who are thinking about new business models, think of home care, think of care traffic controllers, think of the importance of interoperability with minute clinic and urgent care, and the decanting of academic medical centers. I know it's controversial. At the same time, we're sharing more and more data with more and more people for more and more reasons. The Office of Civil Rights and Attorneys General are focused more and more on privacy breach and fines. I've had 2 reportable privacy breaches over the last 24 months, neither of which I could control. One, a private laptop that was stolen, and the other, a medical device that was actually compromised by the medical device manufacturer. And I've spent hundreds of thousands of dollars in forensics and legal fees and working with government officials to try to validate that I did not in any way cause these breaches. Now, we're doing this at a time when the nature of the attacks are not MIT freshmen. They're organized cyber criminals and organized crime. On the eve before the marathon in Boston this year, a hacktivism group called Anonymous decided to try to bring down Children's Hospital, but wasn't quite sure the IP addresses of Children's Hospital, so it ended up attacking the entire Harvard network, affecting Beth Israel Deaconess, the Brigham, the Jocelyn, Dana-Farber, all of the hospitals in this area on the eve of the marathon. That's the reality of what we're dealing with here. It's millions of zombie-infected computers attacking healthcare institutions, not a lone MIT freshman in a dorm room. And of course, as been in the press quite a lot, the idea of medical identity theft. The organized crime would rather steal a medical record than a Visa card, because a Visa card sells for $1, but a comprehensive medical record used for identity theft would be about $200 on the open market. So the threats are real, the threats are increasing. We're doing our best, but at a time when you've got privacy and regulatory compliance enforcement at a fever pitch. So definitely a hard era in which to build more interoperability. So I'm investing millions of dollars this year in identity management and be able to integrate events that occur from a security perspective into common logging systems for analytics and a variety of malware protections. So just, Anthony, a couple of minutes of reflection on social mobile analytics and cloud. You see in our literature, smack, social mobile analytics and cloud will save us all. Be very careful because a lot of the products are actually social cloud analytics and mobile. That's scam. There's a lot compiled in PowerPoint out there in the industry right now. But what's real? Well, one of the things I think about is increasingly care is done by a team. It's done by a group. And the electronic health record as currently organized is about capturing a single episode of care by a single caregiver. It's hard to coordinate using even the interoperability we have today with transitions of care. The vision for the future, and it may sound a little crazy, is that we're going to have to re-engineer the EHRs as they currently exist to be more like Wikipedia and Facebook. Wikipedia, a group of people on a team come together to author a note. It's a nurse, a doc, a mid-level, a pharmacist, a social worker. It is then signed by the attending physician and posted as the official note for the day. It's not 17 different notes with CCDAs flying all over the community. It's a groupware authored note. And then Facebook, the wall. What are the events that happened to you that were salient today? The blood pressure that dropped, the medication that was changed, or the lab result that came back. So I hope over the next couple of years we'll really rethink a lot of the current EHR functionality as we move forward to the care management medical record. We're seeing more and more mobile. I'm sure all of you out there have iPhone 6s, hopefully the small one that doesn't bend. And the iPhone includes the health kit. We're seeing more and more middleware, Samsung doing this too, capable of getting data from your Fitbit and your Nike shoes, your Jawbone device, blood pressure cuff, and bathroom scale. And what's interesting is in the past, it's been very hard for EHR vendors to reach into the home and get this telemetry. The interfaces were complex and privacy controls quite challenging. But if it's going to the device that you have, your phone, it's not a cloud, right? There's no cloud whatsoever involved in the Apple Health Kit. You keep the telemetry on your phone. You decide who to share it with and how to share it. That's interesting. Suddenly it pushes the problem of that bathroom scale, blood pressure cuff, pulse ox interface to Apple and not to the EHR vendors. So I actually am, over the next year, I think we're going to see between iOS 8, Apple Watch, and Samsung's innovations, easier ways of getting home telemetry into the EHR, into the care management systems, variants analyzed, and actions taken. Just two quick photographs to you. The kinds of mobile we're implementing. Standard user interface today in our emergency department, Google Glass. As you walk into the room, a 2D barcode seen by Glass immediately identifies who the patient is, shows you the data about that patient, their triage, vital signs, problems, medications, and diagnostic results. And that's worked really well as a mobile device for procedure-oriented specialists. The Apple Watch, and so yes, Anthony, that's one of my black Kevlar shirts, actually is showing my heartbeat there as I was wearing it. And you can imagine that a heart rate monitor on your watch that looks for variation, or I receive a medication reminder. The watch taps my wrist and shows me a picture of the medication to take. These are the sorts of things that you might imagine innovative companies might create as apps. Last two items, analytics. More and more we are asked to do population health. We're looking for gaps in care. We are having to integrate best practices from across the community based on experience of other patients, including genomic data. So think of the EHR now as just one tiny part of the ecosystem where patient-generated data and mobile devices, care management software, and analytics need to come together. So these are the sorts of things the Standards Committee, the Policy Committee, and ONC, of course, will try to work on. More and more, I think you're going to see as healthcare gets better by getting bigger. I'm not sure that's true, but there are a lot of mergers and acquisitions going on. A need to move to cloud-based computing so that you have the agility of merging, unmerging, bringing on new offices, bringing on new hospitals, sharing records in the kinds of ways I've described. And I think we're starting to see a level of maturity in cloud hosting providers. They will finally sign business associate agreements. They finally understand HIPAA. They understand reliability, scalability, and agility. So I suspect you'll see not only for the clinical care record more and more cloud, but also analytics in the cloud, security controls in the cloud, and learning. How do we keep up with all of this new regulatory and compliance stuff? More and more cloud-hosted content delivery to our docs and patients. So, hey, that is what is going on at the moment, Anthony, and October 15th, next big milestone. Watch my blog tonight for all those details, and look forward to the questions after we hear from Lorna.
Very good. Well, thank you so much, Dr. Halamka. Always appreciate you doing these with us. Now we're going to hear from our sponsor, represented by Lorna Green. Lorna, thanks for joining us today and supporting the event.
Thanks so much for letting me be here. Wow, how much information we got just in the last 30 minutes. I couldn't write fast enough, Dr. Halamka. Thank you so much. I want to give you, Anthony, I apologize. I can't remember how to go to the next slide. Oh, I did it.
There you go.
Smarter than I thought I was. I'm representing OnBase, which is a company by Highland Software, and we are an enterprise content management solution. And this slide is a slide of what we consider the connected healthcare enterprise. We are well aware that your core application is generally your EMR, Epic, Meditech, Allscripts, Cerner, whatever that is. But we, as an enterprise content management company, feel like we can be complementary to your EMR, and we are the central place where you can process and access information that may be out of other applications, would be out of your PACS system, out of your other individual like OB systems, but we can be that central repository where your clinicians can have one place to go and launch in to see all the data. These are the core components of enterprise content management. Obviously, for enterprise content management to be valuable, you have to capture the data. We have numerous ways of bringing in data. We do support HL7 interfaces, and we go all the way back to just plain old scanning. But then the different components of this is we process it, we have workflow capabilities, and then, of course, accessing now in this world, especially of meaningful use, we integrate with portals, give patients and family and clinicians the ability to access their data. And we store it securely. As Dr. Halamka mentioned, HIPAA, those type of things are very important. We're certified for our privacy and security measures for meaningful use. So we know and understand what the important things are to you, and we want to use these components of enterprise content management to complement your EMR and go the next step. We're very happy that our newest edition of OnBase was released. Our editions go by the year. This was OnBase 14. It was just officially released last week. And one of the things that we're really focusing on this year in our next releases is bringing informed care to our users. We have a very comprehensive universal patient viewer and a medical image viewer where all data on a patient could be viewed from the EMR launched into OnBase. We also have clinical device integrations where we can bring EKGs and different types of feeds into OnBase where you never have to print that red copy of the EKG again. You can bring it straight into OnBase for viewing. We also have some mobile capabilities, and mobile, as Dr. Halamka talked about it, and mobile, as we talk about it, may have some different components, but we give clinicians the ability to view patient data mobily on mobile devices, iPhone, iPad, and others. But we also give the ability to take forms and consents that can be entered on an iPad, on a tablet, signed by the patient, and then put straight into OnBase and never have to be printed. We also have the ability to import photos and documents, and straight from our mobile devices, you can take a picture and upload it straight into OnBase. So we feel like these are complementary things to your EMR where we can help you as you're trying to reach some of these goals that we're going through in the next few years. We want to make it easier and give your clinicians a broader experience. We have industry recognition. We have been endorsed by the American Hospital Association, exclusive endorsement, consistently ranked in the top tier class, and we just found out that for the 5th year in a row, we are a leader in the Gartner's Magic Quadrant for Enterprise Content Management. This is my contact information. I would love to talk with you about any of the issues that you're having at your organizations and see if we can help you in any way. So thank you so much. And back to you, Anthony and Dr. Halamka.
All right. Thanks so much, Lorna. We appreciate the support. Okay, now we are ready for our Q&A with Dr. Halamka. Always fun. Let me start off with our first question. Beyond Epic, can the quote-unquote selfie approach be applied to other EHRs? Can you share the CMS FAQ number or some other keywords to find it?
Right. So, Anthony, why don't I do this, is that I will get that FAQ for you and make sure that you can post it for the listeners. But the answer is it would apply to any EHR. As I understand the CMS interpretation, it's simply that 2 different tax IDs have to be used as the sender and the receiver. And since many hospitals don't own their physicians, the physicians, of course, would be part of a private practice with a different tax ID. So any EHR that would be able to deliver a transition of care from one tax ID to another tax ID viewer would be appropriate. And I'm not encouraging people to do this, right? I'm just telling you that that's a ruling that seemingly gives people a little wiggle room as we go through this ecosystem building we're all trying to do.
Very good. A comment someone has sent in that you could respond to if you choose. I like the idea of individuals being stewards of their own data. We need a platform that would allow incorporation of all EHR and non-EHR documents into a single secure repository. This would facilitate health initiatives.
Right. So I trained in county hospitals in Los Angeles, and many people that I treated did not have access to technology. So some people will rely on our healthcare system and our providers to do this coordination of care, and some will want to do it themselves. Well, this is the United States, and I visit a lot of other countries with, say, 5 to 7 million people like Sweden or Scotland. And, you know, in 5 to 7 million people, creating a central repository of everything for everyone works okay. When you're dealing with 330 million people and 56 different sets of privacy policies, that's states and territories, central repositories are at the moment challenging. And I think an approach of more federation, where the data lives in multiple places, but either there is a government-based, state or federal, registry of your relationships with a provider organization, in fact, a pointer to where your data lives, or you have that registry on your smartphone device. So that is, there is a mechanism of being able to do federation because there is a sense of where those records can be pulled from. So I think what you'll see on October 15th at the Standards Committee meeting is this idea that if we would just have standards for things like identity of who you are, relationships that you have consented to disclose, and pointers that allow APIs, the application program interfaces, at the places with your records to send data in real time with your consent, we will have achieved what needs to be done without a giant single repository.
All right. Another comment on the selfie. Regarding the selfie, it was explained to me in a way that it could go between the same tax ID number but had to leave the facility and go through an HIE or HISP and re-enter the organization. Is that incorrect?
Well, and that's correct, right? So, I mean, it isn't. A transition of care idea is that if you write a note in Epic and then someone reads it, that's not a demonstration of the standards or the HISP or the concept of health information exchange. So what I was simply getting at is that you could take a, say, hospital stay, wrap it up into a CCDA, send it over a health information exchange, a HISP, could be vendor-based or could be your EHR cloud. I mean, there's some kind of HISP function here, state-based, and then it may re-enter you. And that is, it has actually gone through the HISP, and then the physician with a different tax ID is able to read it after it has gone through that transmission process. That's my understanding. But, you know, as I said, Anthony, we'll actually publish the FAQ itself, and that way people can read CMS language.
Okay, very good. Next question, regarding the ICD10 readiness situation, I assume you're concluding that folks aren't ready because the testing is going so poorly. Do you think that groups really aren't ready, or perhaps the collaborative testing process was not well designed or planned?
Wow, this must be somebody from Massachusetts. See, too detailed a question. I know who you are.
They gave themselves away?
Yeah, no, I mean, so, of course this is correct. Technically, many organizations have retrofitted their systems, right? Can you enter an ICD-10 code? Can it go out in an 837? Can an 835 be generated? You know, all that technical stuff, yeah, it's actually largely done. It's just a lot of the workflow orchestration, the end-to-end testing, the making sure that mappings of 10 to 9 and DRGs and all the rest are able to function. That's the hard part. So it is certainly true that in Massachusetts we tried to bring all the payers and providers together into a single large collaboration of testing. And Anthony, it's my opinion that the difficulty of collaboration is the square of the number of participants. And so hence what the person was getting at is that, you know, there were probably point-to-point interfaces that would have worked okay. It's just that when you're trying to get a whole community over the finish line at the same time, and that includes small providers and small payers, it's hard. So, you know, long answer to the question, some payers and some providers are ready, the smaller ones mostly aren't, and the testing process has shown gaps in workflow, for sure.
All right. I'll try and get a couple more here. As an HIE organization offering query and direct services, one of the issues I have experienced is that direct vendors believe that only a specific person can use direct accounts. How do facilities handle direct email accounts, personally or organizationally?
Wow, this is a great question from the field. The answer is Beth Israel Deaconess does both. And so we have decided that for most transitions of care, the destination is the electronic health record, and it's patient-centric, not provider-centric. The problem, of course, is that you might have a primary care doc, a specialist, a care manager, a hospitalist. Who do you send it to? And so in our case, when, for example, an outpatient summary or a referral comes into Beth Israel Deaconess, it is received in the record of that individual and available for any caregiver in the context of a visit that occurs here. However, there are some workflows that demand more urgent review of the incoming data. So we are capable through the state HIE of not only an institutional direct address, you know, Beth Israel Deaconess in general, but departmental addresses like the emergency department. So it's going right to a physical location in a queue that is monitored by the folks who are making sure the workflow in the emergency department is completed. And sure, you know, it can go to a person. I mean, that is true. It's just at the moment we haven't found that useful because there are so many teams involved in an individual's care.
All right. I'm going to just sort of a good concluding question. Someone's sort of commenting on a previous discussion and talking about a check-the-box mentality of some of the meaningful use things we're talking about. Do you expect Stage 3 to get back to focus on really meaningful use, perhaps based on outcomes that require appropriate use of HIT to achieve those outcomes? I think they're talking about the selfie situation and talking about a check-the-box mentality that might indicate. So what are your thoughts on if it's going to get back to where some people want it to go?
Well, that's a great question, and that is my sincere hope. I mean, remember, folks, I have not seen the draft, right? That would be inappropriate for me to see it. But certainly the tenor of the discussion in all the federal advisory committees has been having a highly prescriptive, check-the-box, it's raining outside, did you press 3 keystrokes while it was raining? I mean, check the box. That's not what we want. What we want is, did you achieve an outcome? And if we said the outcome was readmission reduction, and whether you decided to do it with Apple Watch or Google Glass or your EHR, I mean, they should all be fine. So what you hope, especially as certification and attestation are decoupled, that you will have a much more flexible, modular approach to selecting the technology and workflow that achieves an end. And in every hospital and every doctor's office, that can be different. Get away from checking boxes that are highly prescriptive.
Very good. Well, that's about all we have time for today. So I want to thank Dr. Halamka for doing these events with us, and thank OnBase by Holland for continually sponsoring them, and Lorna Green for speaking today. As I mentioned, you'll receive an email when our archive's ready, usually within 2 business days, usually sooner, and a separate registration is required. If you've asked us to communicate your attendance to CHIME, we'll do that. If you have not, please make sure you claim your credit for attending today. Questions, comments, contact me as always, and go to our site to see our robust store of archived events and our upcoming schedule. So once again, I want to thank everybody for speaking and joining, and everyone have a wonderful day.